نور ضعيف شكرا.
That's enough. And I have been working with the Turkish Society for more than 25 years. The Turkish Society now is the third largest society in Europe, and the third largest in numbers, and the third largest society in producing scientific papers and publications in Europe. Turkey now has, last year when I visited them, they had 33 PET CT scans, they have 5 cyclotrons across the country, and they expect within the next 3 to 4 years to reach 68 or 70 PET CT in the country. I hope I can see this, and I can see now the Egyptian society is growing fast, and starting to join up, the numbers are increasing, and I hope we see the growth, and my dream is that to see the society continue to produce its work. The society has proved itself that it is the leading society in the ESNMS in our world. My dream is to get Arab society to do medicine and to be stationed here in Cairo, headquartered in Cairo, with all the problems with the Arabs, with all the problems that are political. But when we are scientists, as physicians, we don't risk that. There is only one thing, which is patience in this case. Coming to my talk now, we'll talk about PET CT lung cancer. I tried to condense it as much as possible and to stress only a few points of importance. I'm going to talk about the role in solitary pulmonary embolism. I'm going to present only one slide about what do we do with respiratory movements during acquisition of the PET study. We're going to talk about the role in mediastinal staging, the role in radiotherapy and radiotherapy planning and follow-up after radiation therapy, and what's the role of PET scan in follow-up in general after treating the patient. Why solitary pulmonary embolism is such a problem. The incidence is high, as I'm going to show you on the slides coming after this. The cost to verify the diagnosis will be tremendously high, and the accuracy of invasive procedures is not high. Means finding the expression valves, it's not really quite high. And especially when it comes to benign pathology, means cancer, and there's a cancer cells in the specimen that the diagnosis is established. But when it is benign, usually the pathologist will give you an immunologic report. In addition, there will be different treatments for different organs, because the causes are quite variable. And prognostic implications of delaying the diagnosis of lung cancer, you are really gambling with the patient's life and the wide range of the doubling time of lung cancer, as I'm going to show you in the slides that are coming. This is just to show you from the literature that we have in the States about 150,000 pulmonary nodules, usually detected through routine exam of the patient, either chest X-ray or CT, and most of malignant nodules that are detected, some of the detected nodules that are detected, 10 to 15% could be due to metastatic disease. So it is a real problem. And lung cancer, we know it is the leading cause of death among the industrial countries and also probably non-industrial countries also as well. And survival rate usually is around 50%, but when you diagnose the patient early, the probability of curing the patient would be as high as 70 to 80%, and therefore prompt diagnosis should be established as early as possible. Talking about the doubling time, if you miss the diagnosis 1 year before, in a routine chest X-ray or routine CT scan, and you say follow up in 6 months or follow up in 1 year. What can happen during this waiting period? You could be lucky, you could be also unlucky, because the doubling time varies from 7 to almost a year and a half. So that's why we have to be accurate as early as possible. These are the different causes that can give you false positive causes is completely different and quite variable. Just to show you from the literature that transthoracic castration biopsy or transbronchial are not accurate. It's about 60 to 80% in lesions less than 4 centimeters. And confirming diagnosis again. Just to show you from the literature what the CT, contrast enhanced CT, can do in terms of enhancement of the lesion, of the nodule. If we take into consideration that if the nodule enhances more 25 household units with contrast, that this could be due to malignancy, underlying malignancy, this would be the sensitivity, the specificity, and the accuracy in 119 patients that have been reported in 2006. 79 of them were malignant and 40 benign. That the accuracy of the CT would be 85% versus 93% for the PET, with a p-value of 0.011. And this is a meta-analysis of 40 studies evaluating 1,474 focal pulmonary lesions of different size and variable size. The nodules under 1 centimeter, usually sensitivity is around 65% or so, or 70%. With new technology, better resolution of system, we hope we'll be able to see nodules less than 8 millimeters. But nodules that are 5 millimeters or so, we do not encourage to try to characterize the nature of these nodules by PET-CT. This is an example of a nodule here in the lung cancer that is deep at SUV value of 3.2, and received medical treatment and the nodule disappeared. And I put this example just to demonstrate to you the importance of not rushing to making that the SUV value is a sharp edge or a marker, a divider between benign and malignancy. That can be benign lesions or inflammatory lesions that has SUV above 2.5, which was mentioned to be like a cut line, cut off for differentiating benign from malignant. And also you can have malignant lesions that have SUV values less than 2.5. So we don't take the SUV value as something from the Bible, from the Quran, that we could not really change. This is published this year by Dr. Al-Azraqi and Dr. Fletcher, reviewing 532 patients that were imaged and had been followed up for 2 years. The diagnosis was established in 344 patients. The prevalence of malignancy was 53%, and the average size of the nodules was 1.6 centimeters. Comparing pictures to CT, how do you feel? This is definitely benign, probably benign, intermediate, probably malignant, definitely malignant. So where do you stand here? You can see the numbers and the comparison between the PET and the CT. And for example, you can see that here when it is definitely benign, the PET is much more accurate. It's almost 4 times more accurate. When it's probably benign, the PET is more than 2 times accurate. When it is indeterminate, the CT becomes 25 times more. It's not 25, but the numbers you cannot see from that. But probably malignant, you can see that the gap comes together, and definitely malignant, again, that is better in the accuracy or the confidence value. You can see here, 93 versus 8. What does it mean? It means that definitely and probably benign results on PET and CT strongly predict benign pulmonary nodule. However, such results were 3 times more common with PET. When it's definitely malignant, results on PET were much more predictive of malignancy than were those results on the CT scan. When malignant final diagnosis was, it's approximately 10 times more likely that the benign final diagnosis in participants with PET results been said in the literature, but what's the real life? You ask yourself. If you are the patient and you have pulmonary nothing, what would you do if it is benign or malignant? What would you do if it is FTG positive or FTG negative? And stop at that level with the solitary pulmonary rhythm and leave it for you to decide. If you are the patient, what would you do? What is the optimum breathing protocol for combined PET-CT? We know that the CT can be acquired in seconds. Patients holding breath at which level of breathing we would like to do. But you cannot hold your breath for 15 minutes or so doing the PET-CT. So the patient should be moving, the diaphragm will be moving, the nodules will be moving accordingly. Your co-registration of the nodule seen on the CT and on the PET scan can be misregistered. Accordingly, the SUV value will decrease. Accordingly, the sensitivity will decrease. Therefore, developing protocols like gating breath protocols is essentially and extremely important. There are protocols that are reliable. Some of the protocols are already available. Some of them are still in development, but it needs to be tested in a wide scale of patients and wide range of patients to know the accuracy. I'm sure it's going to be possible and will be a step forward that everyone will eventually, in dealing with solitary pulmonary to consider having a gated respiratory gating on the system. However, at the present time, we see that quiet breathing is recommended for optimum patient comfort during acquisition of the attenuation of the PET-CT. About staging, we follow the international staging system. However, let me show you some of the results in the literature and some of the problems that we have with staging. This is paper published as early as 1991 with the preliminary PET systems at that time, just in the beginning, showing that at that time PET sensitivity or accuracy was ranged from 81 to 96%, depending where you put it, while CT ranged from 62 to 88% and MR from 80 to 50 to 80%. We're talking here about intestinal staging in particular. This is another one from publication from Apple, showing that the sensitivity or specificity and accuracy of CT was 70, 59, and 63% versus 89% for the PET only without the CT. For PET-CT, which everybody is using now, no one is using PET only now, was 89, 94, and 93%. That means what? When the patients ask you, are you sure, doctor, I don't have cancer? What do you answer me? You tell them, no, you don't have cancer because the PET was negative. You're wrong. Because the negative predictive value, that's what the patient cares. The patient cares about the negative predictive value of the test. The positive predictive value is okay. We're going to proceed with it. We're going to prove finally that it was benign or malignant. Thanks God, everybody will be happy despite us spending all this money. But when it is negative and proves later on to be cancer, that is the problem that we have to be aware of. Is that there are some tumors that are non-calorically active, like carcinoma, like carcinoids. There are some tumors that are too small in size to be detected, so we have to be very careful. So every patient should be considered independently in the light of these results, but have to have special attention. Intestinal staging, why it is important. In T1 and 0 patients, 17% had nodal metastasis. The 5-year survival is 91% if it is true negative staging of the patient. The 5-year survival is going to drop from 91% to 30% once they are with this spinal injury. Of course, it depends on the level of the nodes that which is involved, ipsilateral, contralateral, and 20% of the patients had N1 or N2 disease at the time of presentation. Invasive mediastinal staging for lung cancer is definitely something that should be considered in order to verify the results of the PET scan. But when does invasive mediastinal staging should be used or not to be used? In patients with extensive mediastinal disease, there is no need to do invasive staging procedures. For discrete lymph nodes, staging by CT or PET is not sufficiently accurate. For stage 2 or central tumors, mediastinoscopy is preferable because of higher false negative rates of needle biopsy to normal size lymph nodes. Stage 1 or peripheral lesions has no need for invasive technique unless the PET CT scan is positive for mediastinal nodes. Left upper lobe tumors should look for lymph nodes, especially around the oral pulmonary. This is a paper was recently published in 2007 looking at the factors causing inaccurate staging of mediastinal nodal involvement in non-small cell lung cancer in PET studies. Looking into 100 consecutive patients with histologically proven disease who underwent staging by PET-CT prior to lung resection, 33 patients were inaccurately staged by PET-CT. Were analyzed. Why? Why did we do wrong here? What was wrong? Univariate analysis and multivariate analysis was done. The univariate analysis identified tuberculosis as one of the causes, and non-insulin dependent diabetes, to my surprise, was another cause. In multivariate analysis, the following causes were identified as independent factors in causing inaccurate staging of mediastinal lymph nodes. Non-insulin dependent diabetes, history of tuberculosis, of course, rheumatoid arthritis, again to my surprise, and presence of atypical adenomatous hyperplasia and pneumonia, of course, because of inflammatory nodes. Does the maximum uptake value of mediastinal lymph nodes has an impact on the prognosis of the patient or not? This is a question that was raised and was answered in a paper by 2006 looking into almost 400 patients that has 143 patients had N2 disease. There were 1,252 N2 nodes were pathologically examined. The conclusion from this paper was that the maximum SUV of individual mediastinal lymph nodes is a predictor of malignancy. That there is overlap between false and true positive. What does it mean? It means biopsy is essential because it could be inflammatory. Definitive biopsy are required to rule cancer irrespective of the maximum SUV. However, the maximum SUV value, of 3.5 was used instead of the traditional value of 2.5. The accuracy for detection for FDG, PET-CT scan for each N2 nodal station increased at least to 92%. Again, you can't take 3.5 as your cutoff. This is an example here for patients who had a central tumor as well as there is a right supraclavicular lymph node. This is an example. You can see here and you see also on the CT scan. This is the metastasis. This is the patient who had a tumor nodule in prediction was this metastatic disease could not be predicted clinically? I guess it was. But what was the extent of the disease? Where were other lesions? If the patient had bad pain or had pain in the femur, where was other locations of metastatic disease? It does not exclude doing a PET scan for a patient that had already metastatic disease verified clinically or by CT. This is showing a lesion in the femur, and this is showing a lesion in T10. And again, we never forget, we never even report lung cancer. Never forget to look to the adrenals, even if they are normal. Look at them, because you might discover something unusual. Coming to the role in radiation therapy. Since PET-CT has been introduced, radiation therapy treatment has changed in up to 40% of the patients by either reducing the fields because there was distal collapse or increasing the field because there is mediastinal disease. However, radiation is always has its problem. And radiation is only one way to danger, one way to damage, one way to fibrosis, one way to pneumonitis. And once it happens, you can't return it back. You expect more complications in the future because of increased fibrosis, increased insults to the tissues, increased incidence of infection, and so on. So it becomes more and more difficult with time to differentiate underlying recurrence in the presence of radiation, fibrosis, and pneumonitis. However, PET becomes a tool here that has to be used very, very carefully because we're dealing with patients that has been treated, has low immunity, are more amenable to infection, and at the same time, they have a high incidence of recurrent disease, and they have a high incidence of the disease to come back very soon rather than later. So, part of the complications is radiation pneumonitis, radiation fibrosis, post-radiation secondary infection, the need to wait at least 2 or 3 months after radiation before you can do a PET scan to evaluate the treatment response or to evaluate whether there is a residual disease or not. And you have to have a fingerprint of the patient after radiation by having a follow-up scan that you keep it in the file. Like we used to do a bone scan for breast cancer, for example, for stage 1 or stage 2 disease. Why are we doing that? And we know that the probability of having a metastatic disease is less than 0.1% in T1 cancer breast. Okay? Why are we doing it? Because we want a baseline bone scan to go back into the future. So every patient is being treated by radiation in lung cancer with the intention of cure. That's important. With the intention of cure, you have to have a baseline PET scan. 3 months post-therapy or so. So come back later for comparison in the future. PET can differentiate evolving radiation changes recurrent tumor from infection. For infection, never forget the patient is your guide. The treating physician is the captain of the ship. You should listen to him because he knows whether the patient has infection or not, but he might not know whether the patient has tumor recurrence or not. And look to filling in of areas of cases, look to the preservation of the bronchogram pattern, look to the development of the medication and specific programs, This is an example of radiation changes in the lung, and this is an example of cavitations that you can see on the CT with a lot of collapse and a lot of infection around it. Look for contour changes of the fibrotic area. Instead of being straight along the radiation field, look for convexity of this border. That might indicate that there is a tumor growing under this fibrosis. Look into the filling in of the areas of bronchiectasis or bronchogram that were present in previous CT scans post-radiation that are filling in now by a massive fat. Look for interstitial septal lines that might indicate the meningitis spread of the disease. Look for other nodules outside the area of the primary lesion that might indicate the second primary of the disease. Look for areas of bone structure under the areas of fibrosis and district invasion, and look for increasing pleural effusion as well. You can see here how this contour has changed from being flat like that to being convex like that, indicating that there is underlying tumor. Look here for the hip here that has been replaced by a mass here in this patient. And so PET can differentiate in active fibrosis from recurrent tumor, as I'm going to show you some examples here. And it has a high negative predictive value and has to be performed best at 3 months after therapy, although we need more and more studies and literature to report for that. This is a patient that has been irrigated before. You can see the inference. This is the changes along the port of the field of radiation, and you can see that the intense uptake here in the lungs due to secondary infection. SUV here can be as high as 10. I've seen this just 2 days ago at the children's hospital. So SUV doesn't really help you that much. This is an example of fibrotic changes in this patient with no recurrence. This is an example of recurrent tumor that you can see here in this patient. And what do we do when we have a recurrent disease? In 8 prospective studies, this is where summarized in 2004, PET scanning was a valid way to differentiate local recurrent disease from post-treatment changes. SUV value of recurrent disease was significantly higher than the non-cancerous post-treatment changes, and also was significantly higher than the primary tumor itself. A cutoff of 2.5, just as for newly diagnosed lung cancer was often used, would make the sensitivity of 77% to 100% in these 8 reported studies, and specificity from 62 to 100%. And can treated lung cancer, can recurrent lung cancer be treated surgically? In 62 patients here in the report, in 2062 patients had 73 scans performed after surgical therapy for lung cancer. So the intention was here was for cure. FDG patient correctly identified 51 of 55 relapses and gave true negative results in 16 out of 18 remissions, and sensitivity specificity of 90 and accuracy of 93, 89, 92%. SUV recurrent tumor was higher than in benign post-therapeutic changes with a p-value of 0.001. This shows you that the patients with lower FDG uptake has better prognosis, although all of them are short-lived, better prognosis than patients with higher SUV values. Also showing patients undergoing second surgery has better or can survive longer than patients that do not have surgery. I have to give credit for some of these slides to Dr. Homer McIntyre, the Chief Clinical Medicine at MD Anderson Hospital. So FDG PET in recurrence of surgical treated non-small cell lung cancer can accurately and stressing can accurately detect recurrent lung cancer, and recurrent tumor is an independent prognostic factor is the SUV value, and FDG PET helps in the selection of patients who will benefit from surgical treatment. How about the follow-up? Where do we stand with the follow-up? Should we make an open door for everybody to come in and have a PET-CT scan and you get rich and they don't benefit? What's the role? We have many new technologies, but which one we should use? What is their impact on the cost effectiveness in asymptomatic patients? And I stress asymptomatic patients, because when the patient is symptomatic, it is justifiable for you to do whatever you think is good and going to guide you and help you with handling the patient's problem. The rationale for follow-up is that many patients of lung cancer treated radically, they will fail in the first 2 years after treatment. And that the long-term survival of these patients is less than 50%. And the salvage treatment is less effective than the initial treatment of these patients. And the second primary cancer in long-term survival is something that we can deal with. So, the points of concern in follow-up in using PET-CT in patients follow-up for lung cancer was the intention of treatment originally for cure or for palliation. Is the patient symptomatic or asymptomatic? In case of recurrence or residual disease, what is the treatment that you're going to offer the patient, and what's the life expectancy of these patients? When I looked at the ACR recommendations in 2005, it was published recently, I was surprised that PET scan was not high on the recommendations, which is, they have a reason and logic for that. If you think, when it from 1 to 9, where 1 is the least recommended, 9 is the most recommended, you find that in a middle-aged patient, as an example, who was 3 weeks post-operative, stage 2 squamous cell cancer, asymptomatic and still smoking, recommendation for PET scan is only 2. Means you don't need it. CT scan will do. A new adjuvant patient who received new adjuvant chemotherapy, radiation therapy, and surgery, exposed everything in stage 3A disease with no residual disease, recommendation for PET scan is 2. While a patient who is heavy smoker with unresectable 3A adenocarcinoma of the lung, who is under chemotherapy, the recommendation for PET scan is 4. Improved. The American Society of Clinical Oncology published some guidelines, if you can reach it, in order to maintain a regular, and recommended that patients should have a regular physical exam, and they did not advocate regular imaging in asymptomatic patients, unless there is a suspicion by the clinician. They acknowledge the advantage of low-dose CT for routine follow-up patients, and for symptomatic patients, they acknowledge established imaging studies like PET-CT and other tests, and disappointing results for salvage therapy after recurrence. For the sake of time, I'm going to stop here, but I would say that studies from the literature show that the yield in this patient is that only 3% of these patients, when we use the PET-CT for follow-up, only 3% of them were amenable for a second surgery. So now you can ask yourself the questions. I'm not giving all the answers.